Okay, so what we're going to look at today is biomechanics in the elderly. And before we go into sort of too much depth with this, most importantly, I think I really need to thank a podiatrist from Edinburgh for this presentation. Her name is Hannah Paul. So hello, Hannah. I'm not sure if you're listening or not. But basically, this presentation was her idea, and she did create a lot of it. So Hannah basically highlighted a very valid point, and that's that biomechanics is important across all age groups, and it's just as important in the little old ladies that we see in clinic that come in regularly enough as it is in our elite sports patients. So we as practitioners can have an impact on the quality of life of all sorts of patients. So, you know, it could be something like prolonging a sporting career in a professional football player, but I think it's just as important prolonging the activity or an active quality of life in elderly people as well. So both are very important, and, you know, sometimes that's easy to forget. And I think as well, elderly patients aren't seen as the most attractive things to treat sometimes when you're thinking about biomechanics, and I certainly know a lot of clinicians who just like looking at their sort of elite sports people that don't have any ongoing medical issues. So I don't think we recognise that biomechanics, as I say, issues with biomechanics is just as prevalent, if not more prevalent, in elderly patients. Now, if any of you are in private practice or the NHS, you'll know that elderly patients pretty much take up most of your caseload. So it's not very often someone like David Beckham wanders in with a foot problem. Most of the time, it is your elderly patients that you see. So I guess the question is, are we recognising any of the sort of biomechanical issues with that? So what are we going to cover today? Well, we're not going to go into deep and conflicting depths of biomechanical theory and the what and who conflicts it, and, you know, various things. We're not going to do any physics either, so as I say, it's not going to be too hardcore biomechanics. The only taxing thing we will address is the anatomy, but I think if we're all perfectly honest, this is all an area that we could do with rehearsing or improving on anyway, so we will touch a little bit on the anatomy. But then we're going to look at the main issues and conditions which contribute to biomechanical instability in the elderly, and then we'll also look at some management options as well, and then draw a bit of a conclusion from that. So just checking everybody can hear me. Someone just said it's not even on a full screen. Yes, I can hear. Right. It should be full screen. I don't know. I'm sharing it. Can I just have a couple of comments to make sure everybody else can see it okay? Okay, I'll keep talking. As I say, if there's any issues, we'll have to work out a way to deal with that afterwards. So is it a growing problem, and could we be doing more? So the elderly population in the UK is certainly growing. More people are living for longer with more health conditions. And we all know that elderly people, keeping them mobile is essential to both their mental and physical health and well-being. Yeah, interestingly, when I look, there isn't a huge amount of evidence for this, or should I say there isn't a huge amount of evidence if you look specifically at the biomechanics side of this. Now, we all know poor mobility in the elderly increases the risk of falls, and that's well documented. It's in the NICE guidelines. And lower limb mobility disabilities are well understood in older people, but causes in middle age have attracted little attention in the literature, which is easy. So it's almost like we split people into young, healthy people and old people, and there's quite a bit of a gap for the bit in between for the middle age. So that's interesting. So here we go with a little bit of an anatomy reminder. So we've got two pictures here. One on the left is showing your main foot muscles, and on the right there's a little bit of revision there for your leg muscles. But we are going to go into a little bit more depth here, looking at the intrinsic muscles of the foot, because these are quite important, and I'll come on to the reasons for that a little bit later. So either you'll remember this, or you've buried it deep in your brain and haven't gotten it out since studying days. If you don't know these, then it's worth printing them off and perhaps having them up in your clinic as a reminder. I know I'm certainly guilty of thinking, oh, they're only little muscles, they're not important, but actually there's a lot of research now that shows how important these little muscles are in protecting the joints and actually protecting the larger ones, and as I say, we'll talk about that a little bit later as well. So here we go, this is the first layer. So this is directly below the plantar aponeurosis or the plantar fascia. And what we can see there is the flexor digitorum brevis. So it's a large central muscle located immediately below the plantar fascia. And its function is to flex the second, third, fourth and fifth toes, and then it's bordered by the adductor hallucis and the adductor digiti minimi. Okay, so that's our first layer after we've gone under the plantar fascia. Then we come to the second layer. Okay, so this is the quadratus plantae. Anybody that speaks Latin will probably be horrified at the way I pronounce these. It's located below flexor digitorum brevis, and it inserts into the tendon of flexor digitorum longus. And this is also where the lumbricals originate, which are a little bit further down. Okay, so there's our second layer there. Okay, now let's look at the third layer, just a bit more on here. So we've got the oblique head of the adductor hallucis, and that joins the adductor hallucis's transverse head on the lateral side of the hallux. Actually, that's quite interesting because you see you've got, I was going to talk about you get more pull on one side of the hallux as you do the other, and I've had a discussion before as to whether that means you're more prone to getting bunions. But anyway, it's quite interesting when you look at anatomy because it makes you think more critically about what's going on. Anyway, back to the picture. So medially to the adductor hallucis are the two heads of the flexor hallucis brevis, and next to the tendon of the flexor hallucis longus. Then there's flexor digiti minimi brevis on the lateral side there as well. So a little bit hard to see, but to say definitely worth looking up and having a revise of some of these. So then fourth layer. So dorsal and plantar interossi, and they're located between and below the metatarsal bones, and they act as antagonists. So basically one relaxes as one contracts and kind of vice versa. So that's right sort of deep in there. Oh, okay, somebody has said, I can see the slides fully. If people can see the question and answer, there's a little arrow to minimise it. Everybody else has said, fine, refreshed, it's okay, hearing you loud and clear. Right, thank you. Okay. The last thing I want to do is get to the end, like 45 minutes later, and find I've got loads and loads of questions saying I can't hear a thing, can't see a thing. What on earth have you done? So, okay, we'll carry on. Right, okay, well, that's your revision over with. Now on to what causes poor biomechanics in the elderly. Okay, and we're going to go into these in a little more depth. So one of the main things is poor proprioception, muscle weakness from lack of activity, that's very common, and bone weakness due to things like osteopenia, osteoporosis, general overall poor muscle strength, cognitive impairment, gait balance disturbances due to illnesses or perhaps surgery, and then also possible pre-existing biomechanical and gait issues. So always important to make sure you get a proper history just to see if there's any of those sort of flagging up. Now, proprioception, so it's first defined by Sheringham well over 100 years ago, 1906, as the perception of joint and body movement as well as the position of the body and body segments in space. So generally poor proprioception results as a result of aging nerves and mechanoreceptors and poor vision. So it's sort of elderly changes going on which basically mean that their proprioception isn't as good as perhaps it was. A study there in 2007 established that poor proprioception in the elderly was a huge risk factor for falls. So there was quite a link found there in that paper that elderly people had poor proprioception and they were more prone to falling. And then as a result of that, you've got the whole knock-on effect if you've got patients having falls. So that can result in further hospitalisation, further issues. Maybe they've had a fall, they've had a broken hip and so on and so forth. But also then you get things, more the psychological side of things, like isolation due to lack of confidence. So if they've had a fall and perhaps fractured something or had some sort of injury, they're then more likely or less likely to go out because they're scared of it happening again. And of course then they're sort of cut off from going out and about, so that affects their quality of life. So the whole thing it's a bit like a domino effect. Neuropathy is also thought to play a part. So think here about your type 2 diabetics or other conditions where neuropathy is a part. So if you've got patients that have got either severe or even small amounts of neuropathy, this will also be having an effect on their proprioception, which can then have that knock-on effect on falls and, as I say, everything else on there. So one thing tends to lead to another, and there's also usually multiple factors when it comes to elderly patients. So Okay, now it's important to remember we still live in a world where some elderly patients may have grown up with poor nutrition, and they may also have been affected with conditions such as polio. I haven't seen many patients like that, but I can think of the odd one I've seen on the NHS in the past where they've had polio and sort of everybody comes in and has a quick look, 'cause it's not that common, but it does happen. And things like this can be underlying factors. So again, this is why it's always important to take a good history. So there's the whole sort of concept and thought of use it or lose it, so which is quite prominent with muscular weakness. So if they're not doing activity or they're not doing exercise, then those muscles tend to weaken, and then again you get knock-on effects. Muscular weakness can be caused by illnesses, so even going back as far as childhood illnesses. And also poor muscular repair in the elderly is associated with poor overall repair. So again, degenerative changes, slowing down, this can have issues as well. Muscular weakness could be related to depression in the elderly. Now, I can't for the life of me remember where I read that, and I do need to get the reference for it. But again, as I recall, the link was basically they weren't able to do as much as they used to be able to do, weren't able to get out, weren't able to socialise, and then this sort of led to isolation, depression, knock-on effect from there. So, but I must find the reference for that. So I think it's also about thinking about the bigger picture, because just because you've done an assessment and found out they've got a weakness or an issue or poor proprioception, it's about thinking about how that's going to impact and affect on their lives and what we can do to help that. Now, osteoporosis, so weakness in bone strength due to age, medication or dietary factors. This can cause instability in the foot during gait. Poor muscular strength is also associated with poor bone strength, and again I think because it's osteo we just think it's just related to the bone, but actually with osteoporosis it's not just a weak bone, it's weak muscles as well. And ankle fractures are the most common in osteoporosis. And interestingly as well, if you've had an ankle fracture, then you're likely to have issues with sagittal plane blockade and things like that during gait. So if you haven't got enough range of motion at your ankle joint, then that has a knock-on effect in other places and can cause issues. So another thing to bear in mind. Now, cognitive impairment. So this is when a person has trouble remembering or learning new things or concentrating or making decisions that affect their everyday life. But associations have been found between Alzheimer's and dementia and muscle weakness. And in this paper here in 2014, they described a link in mild cognitive impairment and Alzheimer's disease as significant, but found that it couldn't be analysed to which stage was the most significant. So they found a link, but it looks like a little bit more research is needed in that area. To quote the paper, all aspects of balance control deteriorate with increasing severity of cognitive impairment, and that executive function plays an important role in balance control. So there's a very obvious link there. Seizure activity in vascular dementia has also been linked to muscular weakness. So I must admit, until I started sort of investigating this presentation, I wasn't quite aware that so many things affected muscular strength. So I've certainly learned some things from this as well. And then we've got general illnesses, and there's a few on here, but obviously there are many, many more, but just to give you an idea. So connective tissue disorders like arthritis, CNS, strokes linked to peripheral vascular disease, epilepsy, seizures. So that's just a few, but usually with elderly patients, sort of few of them, especially if they're coming in to see you anyway, come in, you know, very healthy with no medical conditions. Okay, pre-existing conditions. So this ties in a little bit with what I said earlier about taking a good history, because pre-existing conditions can have quite an effect. So it's common to forget that elderly patients have also been young and may have had a previous condition or injury. And there's actually been a lot of research looking at the effects of ankle inversion injuries. So people that have had inversion injuries sort of 10, 20, 30, 40 years ago, and they've done precious little about it at the time, and then problems have manifested themselves in later life and caused problems. In fact, there's a lot of a push now to accurately diagnose ankle injuries when they first happen and get the best medical treatment there and then early on, because then it sort of saves getting problems, osteoarthritis, lack of range of motion, joint problems, and so on and so forth as these people get older. So, but there's been an American study done, and it was, I can't remember which journal it was published in now, but it certainly showed it was a huge range of issues which occurred just from having an ankle injury, which at the time most people probably think is completely insignificant. It's probably even worth asking the question, because I think to most people having an ankle injury 30 years ago or an ankle sprain probably isn't high on their sort of radar of issues wrong with them. So often these conditions could have gone untreated, which may cause problems as they age. I find elderly patients sometimes are notorious at completely forgetting things, like having broken limbs and various things when they were younger. So as I say, it does take a bit of teasing out of them sometimes, which is difficult if you've only got 20 minutes for an assessment. But it is important that conditions are dealt with when patients are much younger, but obviously by the time you've got to see them, it's a little bit late for all that. So that's something to instill into your younger patients maybe. But yeah, pre-existing conditions, pre-existing injuries, definitely need to get to the bottom of that before you start looking at management. And here we go, management. Now, obviously, management is specific to individual needs, individual patients, and we may adopt different management strategies depending on that person, their lifestyle, their surroundings, their medical history. But I've got a few here that I'm going to go through, and then we'll go into some more depth into each of them. So we've got stretching on there, strengthening the intrinsic foot muscles, and that is why I put the anatomy slides up earlier, because we're going to go into that in a second. Support of any problems further up the body via occupational therapy. This is where your multidisciplinary team comes in. Orthotic Therapy, so insoles, orthoses, and then basic exercise as well. So, now obviously management. Oh, I can't see the bottom of my slide. Management. Oh yeah, no, I can talk about a paper here. Right. So this was an interesting paper which I've stuck in here. It was published a few years ago in the British Medical Journal, and it was a parallel group randomised control trial, and it looked at 305 elderly men and women in the community with disabling foot pain. So basically they split the group in half, or pretty much in half. So 153 were allocated to what's called a multifaceted podiatry intervention. And that didn't just include one thing, it included a range of different treatments. And for this study, they included foot orthoses, advice on footwear, subsidy for the patients to go and buy the correct footwear. There was also a home-based foot and ankle exercises program, a falls prevention education booklet, and also routine podiatry care for 12 months. So one group got all of those things, and then the other half of the group, the other 152, they only received the routine podiatry care. So they didn't have orthoses, didn't have footwear advice, didn't have the right footwear, didn't have home exercise program, didn't have anything of that. They just had the routine podiatry. And what they found with the 12-month follow-up was that the intervention group, so the one with all the management strategies in there, that intervention group experienced 36% less falls than those that only had routine podiatry care. So that's a really significant, I mean, that's well over a third. So it really, really highlights the importance of our intervention, but not just our intervention, a mix of picking the right sort of management. So looking at exercises, looking at orthoses, looking at education, that's really important as well. So sort of the whole shebang. I think I've said this on a webinar before, but somebody once said to me that any intervention which you offer is like the ingredients of a cake, and actually your overall treatment or management is your whole cake. So orthoses might be like putting your butter in, your stretching exercises is your sugar, and then you've got you've got other ingredients there as well. But if you put all the ingredients in, you get the best outcomes than just putting the sugar in, or just putting the butter in, or just doing the stretching exercises. So stretching exercises, they're always a good all-rounder. Most people have got tight calf muscles, although you do obviously have to check it's not a bony blockade and they've not got osteoarthritic changes, and no amount of stretching is going to change that. But there's plenty of evidence to back up stretching, and they also work really, really well when prescribed alongside other treatments such as orthoses or muscle strengthening. The other thing I found is that it can also act as putting a little bit of a psychological onus back on the patient to participate in their treatment. So rather than coming in and them wanting a pill or a pair of insoles or you to do all the work for them, it does sort of engage them a little bit more to kind of help them help themselves. Doesn't have to be hardcore stretching. You've got to think as well, these people have got to actually be able to do it. Even one of the best things I find are those calf stretching boards that you can get them on Amazon now, actually, that you can set at different inclinations and just set it somewhere while they're brushing their teeth, peeling their vegetables, doing their hair, having a shave, something where they're going to be stood for a couple of minutes, a couple of times a day anyway. So if they're going to be stood there, not walking around and stood in one place anyway, they're more likely to do their stretches, and that's just something that I've found. But as I say, you must do your assessment first, because if they've got a ankle joint fusion and you're trying to get them to stand on a block to stretch their calf muscles, it's going to cause more pain than healing. Right, okay. What slide are we on now? Right, I think can't remember what I was thinking with the slide. Education, I think. Education is something which has come up in the research. There's a chap called Peter Malliaras who does a lot of work on muscle loading for the Achilles tendon over in Australia. One of the key points he points out in his research is getting your patient on board with the treatment you're prescribing, because essentially if you're relying on them to do stretching, do strengthening exercises, do loading exercises, whatever, if you haven't educated them enough and they haven't accepted that and kind of agreed to do it, then you're completely wasting your time with it. So I think muscle strengthening is an area where we can really make quite a big difference with this. But again, as I say, it is putting the onus on the patient, so it does take a little bit of time getting them on board with this. And if they're the sort of people that have never done any exercise in their lives, this can be a little bit tricky. So muscle strength can be kept into middle or older age, but it does take work, and unfortunately that work is not something we can do for them, that's something they can do. So okay. So ankle strengthening. So it has been found that runners with weak plantar flexors are predisposed to ankle injury, and the research there suggested that the same concept could be applied to elderly for falls prevention. So smaller muscles, the big key thing here is smaller muscles react faster than the bigger ones. And to quote Benno Nigg, keeping the smaller muscles strong helps prevent injury on the larger ones. So I watched a presentation by Benno Nigg a couple of years ago, and he really emphasised how important the smaller muscles all around the ankle joint were in keeping that joint healthy. And basically what he said is if they're weak, and he had tons of studies to back this up with EMG and goodness knows what else, sort of high quality studies that he carried out. But what it showed was that if the smaller muscles were weak, then basically it just put a lot more onus on the bigger ones, which then made them more susceptible to injury because of the stress placed on them. He also found that the smaller muscles in a healthy individual react faster. So if you do go over and start to have an ankle sprain, then they'll react faster to rectify the foot and help protect the larger muscles. So if these muscles are weak, then you're more likely to go over, more likely to sprain an ankle, more likely to get an injury, and more likely to pull one of the larger muscles. So you mustn't forget the small muscles. It's not just Benno Nigg who's written about this. Luke Kelly and Kevin Kirby have also emphasise the importance of muscle strengthening around the plantar arch, so your intrinsics. And what they've said is that the smaller intrinsic muscles play quite a substantial role in stabilising and maintaining that medial arch. So back in the days when we sort of read Dannenberg's papers, and it was all about the loading the foot, going up onto your forefoot, engaging the windlass mechanism, and the foot locks. What we think happens now is that the foot doesn't lock, but those muscles become gradually stiffer to give you a stiff, rigid lever, to quote, to then push your body forward. So we're relying on those smaller intrinsic muscles to stiffen up the foot to hold it in a stable position for normal gait. So if they are weak, then essentially that just puts more pressure on some of the other structures like the plantar fascia, the post-tib, your flexors, your perineals, and basically the other layers. So the whole foot won't completely collapse, but you're just taking one element out. So it's a bit like having a car where you haven't balanced the tyres properly. You'll get issues elsewhere as a result of that. Right, so there's a little slide there with some pictures on just to give you some ideas, because it's all very well me saying about do strengthening exercises, but what can you do? Again, this really comes down to your patient and what they can do. So say there's no point getting them balancing on a wobble board if they need a mobility scooter to get about with. So one of the things you can try is towel curls, so placing a towel on the floor and then getting the patient to curl it towards them. And then you can increase the resistance on that by putting a weight on the end of the towel. So they're dragging the towel, but there's a resistance on it. So that's something you can build up slowly. And then I've put there repeat 5 times, but again, that's completely dependent on your patient and what they can do. But you build up putting a weight on the towel, and you build up the amount of repetitions sort of depending on what they can do in the first place and how well they're getting on with it. We've got toe pulls on there, so putting a thick rubber band around all your toes and spreading them. That is dependent on your patient being able to get down to their feet. So if they can't get down to their feet, you'd be better off with the towel curl one. And then picking up marbles. Could be marbles or picking up a pen or any object on the floor. In my house, looking around me now where my children have been in my office, it's Lego. But picking up one at a time with your toes, and then, as I say, repeating 3 times. Cotton wool balls have also been suggested instead of marbles. So again, you've got to think a little bit, because if they've got neuropathy and all those sorts of things, you don't want to be giving them an injury. So that's not a hard and fast rule. Those foot exercises is just an idea, things that you can do. Now, this is an interesting paper. And if you think you're going to start advising foot strengthening and focusing on this with your elderly patients, this one's well worth a read. The only thing is, if you Google the foot core system, some sites will claim that it sort of cures everything from flat feet to the whole works. So I mean, it's a good exercise, but it doesn't cure flat feet. It's not the be-all and end-all to everything. But if you take it as it is, just as another addition to your treatment, in your treatment toolbox, if you like, it can work really well alongside other exercises or treatments. So the paper by McLaren in 2014 stated that there was no gold standard for assessing the function of the intrinsic foot muscles, which was a shame, because I was hoping I'd find a really good paper to break that down and tell you how to do that. But they said there was no gold standard, so you kind of got to work on what you can see, really. It said as well, the arch is controlled by the local stabilizers and global moves of the foot. And what they basically say is that the way the foot works is comparable to the lumbo-pelvic core. So most of your patients will be aware of pelvic floor exercises and core stability and core muscle exercises and a strong lower back. And it's basically taking those principles and putting it into your foot. And they've come up with this exercise called the short foot exercise, which we'll look at on the next slide. Another pop-up. Go away, pop-up. And what the evidence suggests is that it can improve navicular drop, arch height index, balance, and chronic ankle instability. There's been a few other papers as well, which have sort of said it's not proven as well as it could be, and there is some debate over this. But I've started using this, and I found it's worked really well for patients. So have a go and see what you think. So this is what it is essentially. It's basically you've got your foot on the left-hand side, and then you draw the foot up, kind of as it shows on the picture on the right. Now keep an eye, if you're not already on the LBG Medical Facebook page or you're not getting our emails, sign up to them, because we are in the process of coming out with a patient leaflet with some advice for intrinsic foot muscles on there, and that should be coming out pretty soon. So something you can have in clinic and something you can give out sort of there and then to your patients after you've explained it. Now, bear in mind, it's only a guide, it's not War and Peace, but it could be useful. So the short foot exercise is one that we put on there. And as I said, it's essentially the foot version, if you like, of your pelvic floor exercise. So suck and hold. Now, if I quote the paper, it says the foot is shortened by using the intrinsic muscles to pull the first metatarsal phalangeal joint towards the calcaneus as the medial longitudinal arch is elevated. As the arch raises during this exercise, it is also referred to as foot doming. So basically, you're sort of drawing the foot together to raise the arch. Now, when you do this, it's important that your patient learns roughly where your subtalar joint neutral is, because that's the position they want to be holding their foot in. So you have to kind of go through it with them to start with. And the calcaneus and the metatarsal heads need to remain on the ground without them flexing their toes. So it's quite tricky because basically you only want to be using your plantar intrinsic muscles, not other muscles. And actually when you try this, it is quite tricky to do. And I know when I try and do it, I always end up clawing my toes just naturally, instinctively. So you don't really want to be clawing your toes. You literally want to be shortening your foot, but only using, probably better off saying your arch muscles, because if you say plantar intrinsics to your patients, they'll wonder what on earth you're going on about. You probably want to start your patients doing this from sitting, but you can also progress to standing, or if they're really sort of doing well, you can get them standing on one leg doing it, because then that will help fire your ankle, your small ankle muscles as well. So, as I say, if you can't get the information from this PowerPoint, although you will be able to watch it again afterwards if you want to, but if all the information isn't on here, look out, because we have got a leaflet coming out soon. So. Okay, I've only got a couple of slides on orthotic therapy, and in my clinical experience, this is it's been a massive benefit to a lot of patients for a huge number of reasons. So it can either be a prefab or a custom made. So and there's a number of different reasons why I've prescribed orthoses to elderly patients. So it can be supportive or functional depending on their needs. You know, sometimes I'll get a 75-year-old marathon runner that comes in that they're very flexible, they've got good ranges of motion, and they're getting, I don't know, medial tibial stress syndrome on the 21st mile or something. So that would be a different orthotic therapy than I'd give to someone who had no range of movement, was overweight, had diabetic neuropathy, and all sorts of other issues as well. So different horses for courses. Whoops, I got carried away there. Okay, elderly patients can respond well to a functional orthotic depending on their range of motion, so very important to check that. It's no good putting them in the perfect foot position if the foot won't go there or doesn't want to go there. And it's the same with things if you're going to be doing first met cutouts or kinetic wedges or things to engage the first MPJ to help with the windlass mechanism. If they haven't got the range of motion in the first MPJ because of osteoarthritic changes, then actually you're going to make it even more painful by doing sort of cutouts and what have you on there. So in some cases you might almost be better putting something stiff under the first to protect it rather than trying to get it to move. And don't forget, in orthotic therapy even just comes your two-dimensional cutout of a piece of polyurethane or poron. So often due to the lack of adipose tissue, a soft orthotic is indicated. So polyurethane or poron is a good choice there, and all that's basically doing is replicating the fatty padding which they once had and has disintegrated with time. So I've just put a few keywords on the right hand side there. So support, protect, correct, offload, and it's just to think about what you're trying to achieve with that orthotic. Orthotics or orthoses aren't all about, you know, hardcore carbon fibre functional devices which hold the foot in a perfect position. There's all sorts of reasons, and even as I say, a two-dimensional soft inlay is an orthotic of kind. So you know, you may already be doing this, and you probably don't even realise you're doing biomechanics. See, so okay. So as I said, you don't have to be prescribing fully functional prescription orthoses. Even an unposted prefabricated orthoses can feel better for your patient. So if you look at all those, I mean, that's the BioAdvance I've just put up there just because it's one of the most popular off-the-shelf devices in the UK. Medium density is the most popular. I think that's just because it's a safe bet. I don't think there's any research that says medium density is better than hard or soft density. Now, it comes with various different components, but as I say, even if you just want to put it in just because it's got a bit of arch support, it supports around the heel, supports underneath the met head, so you're not even messing about with changing the angle or the biomechanics, you're literally just putting an insole in there. Even that alone can feel better for the patient and also make them feel more stable in some incidences. So there's tons of research out there looking at how orthoses work, and that's a completely different presentation. But what we do know now, and what's become a lot more prevalent in the research in recent years, is that orthoses do not work by magically realigning everything. So you remember those old pictures you used to see with somebody standing with flat feet and internal rotation and bent hips and bent back and everything else, and you just put them on a pair of orthoses and everything's perfect. We know now they just don't work that way. So on some people, they'll be magically realigned, but it's not the same for everybody, and you can't predict it. So we kind of have to get away from that way of thinking. What we do know is that comfort plays a key. So if you put a pair of I don't know, soft density or medium density EVA devices in your patient's shoes, and it feels comfortable, the chances are that's going to help. And also, you don't need to be a biomechanics guru to work that one out. Just put it in. Is it comfortable? Does it feel better? Yes. Okay, let's give it a go. Okay, multidisciplinary team. So never forget them, especially with elderly patients with other stuff going on. So elderly patients can benefit from a multidisciplinary team. So think physio, osteoporosis, occupational therapists, orthotists, podiatrists, if you're not a podiatrist watching this. Physios are great at helping to strengthen the core and the torso of the body. Sometimes I think it's very easy to think if you're a podiatrist, you just do the feet and the lower limb and you forget what's going on elsewhere. I've worked with some physios that have done some absolutely great stuff, and it's really complemented what I've done and vice versa. But then also occupational therapy can provide equipment, so like walking aids, frames, sticks and all that sort of thing. I mean, that could help as well in certain instances. So you're not alone. Don't forget these people are out there. And this is last but by no means least. Don't forget the importance of regular exercise and the importance. Well, it's important not only advising it, but also convincing your patients to take it up. So it's not a case of just writing in your notes, yep, advise them of exercise. It's really, really important to get this into them. So it's often overlooked. There's a trial there in 2011 looked at the effects of gait efficiency and gait improvements on patients who did light basic treadmill exercise. And they found positive outcomes. But also it benefits the whole body. So it's not just going to help strengthen the foot or help with the gait. You've also got to be thinking about your cardiovascular system, losing weight, respiratory systems. Everything is improved by basic fitness. And there's a new study, this was only published this year by the British Medical Journal. And it looked at walking. Essentially it said if you've got somebody that can't walk further, then all you need to do is increase walking pace. And this was found to be beneficial. And as I said, I can't remember how many participants they had in that, but it was quite an interesting piece of research, and I'd say worth looking up. So, but yeah, increase walking pace rather than increasing distance, because sometimes people haven't got the time or the energy, or people are often resilient to doing more work themselves. So you've got people with a pedometer, patients with a pedometer rather, and then this could be a way of getting them to do more exercise without increasing the amount of time that they're doing it for. So well worth considering this, and not to overlook basic exercise education as part of your overall management. Okay, so that's sort of pretty much drawing us to a conclusion. So it's important to remember that we do see far more elderly patients with biomechanical issues than we see sports stars, unless of course you're a clinician that only sees sports stars, in which case I very much doubt you'll be watching this presentation anyway. Biomechanics isn't just about prescribing orthoses, and I know for those that often I've asked when I've sort of done, not webinars, but presentations to real people rather than sat in my room looking at a laptop like I am now, I normally get a show of hands as to who likes biomechanics and who doesn't, and normally pretty much it splits the room. And the reason people don't tend to like it is because they find prescribing orthoses complicated, there's so many different theories. And also, you know, if you go on something like Podiatry Arena, people can come down at you like a ton of bricks if something's sort of said wrong or so on and so forth. So people are often scared of it, so they don't bother trying to get involved in it at all. But biomechanics isn't just about prescribing orthoses. It's about giving education, it's about stretching exercises, it's about strengthening exercises, it's about employing a multidisciplinary team. And also, if you think somebody does need prescription orthoses and you're not confident, then refer on to another podiatrist who is. So I think biomechanics really should come into sort of every elderly patient that we see, really. Especially with things like the at-risk foot, because there's so much you can do for offloading as well. So there's far more you can offer as a clinician in terms of advice and exercise prescription, and this was certainly something that I didn't do in the early days. I sort of saw it as I did stretches, I did orthoses, and that was it. But actually muscle strengthening is now something that I really probably prescribe to just about everybody I see. So that's really changed my practice. And if you do prescribe orthoses, as I say, that ties into what I just said, don't forget your muscle strengthening too. So often the two things work together, or 3 or 4 different types of treatment work together well, better than just doing one of them. So strengthening exercises alone won't do as well as maybe strengthening and stretching and orthoses and education, if you see what I mean. So think about the bigger picture. And also everybody's different. So you might have 10 patients that come in with the same, I don't know, arch pain for argument's sake, but you might do very different treatments for all of them, depending on what their circumstances are. Right, okay, I'm going to wrap it up now. If any of you do have any questions, then do email in.